Sí, buenos días, queridos amigos. Estamos en el marco de las actividades del 25 aniversario de la Sociedad Mexicana de Cirugía Cardíaca. En esta ocasión nos encontramos realizando esta entrevista con con el profesor James L. Cox. El profesor James L. Cox es el creador del procedimiento de Cox-Maze y es el principal artífice en la cirugía de fibrilación auricular. Dr. James Cox, many thanks for your assistance to this our meeting. Dr. Cox is one of the principal actors in the surgery of atrial fibrillation in worldwide. He is the creator of the Maze procedure, and there are so many things, dear professor. Firstly, welcome, dear professor.
Well, thank you so much. This is actually my first visit to Mexico, and I've wanted to come here for many years, and I've been extremely pleased and impressed with the hospitality, the food, and the associations here. So thank you so much for inviting me.
Okay, thank you very much, Professor. And firstly, how did the idea of the atrial fibrillation surgery arise?
Well, a lot of people don't realize that for about 15 years or so before we developed the Maze procedure, we had developed operations for other arrhythmias, essentially all the other arrhythmias that a patient can have that are resistant to medical therapy. Those included the Wolff-Parkinson-White syndrome, which Dr. Seeley, one of my teachers, had developed an operation for. I modified it several years later, and then developed an operation for AV node reentry tachycardia, for left atrial automatic tachycardias, for right atrial automatic tachycardias, for non-ischemic VTAC, and for ischemic VTAC. The ischemic VTAC procedure was actually developed primarily by people at the University of Pennsylvania and so on. But nevertheless, we had developed a lot of operations and participated in a lot of operations for arrhythmias other than atrial fibrillation. The only remaining operation, the only remaining arrhythmia for which an operation had not yet been developed was atrial fibrillation. So we started focusing on that almost exclusively around 1980. And from that point on, we developed, my colleagues developed electrophysiologic mapping systems so that we came to understand the atrial fibrillation better. And once we knew exactly what was going on, then we were able to come up with a reasonable plan to attack it. All the previous operations that we developed were based on intraoperative mapping. So we would do an electrical map and then go to the site of abnormality and fix that site. With atrial fibrillation, because the rhythm abnormality moved around continuously, it was not possible to do that. So we learned after much trial and error that was not really possible to map the atrial fibrillation in an individual patient and then do an individual operation on that patient. So our fallback position was that we will do an operation that precludes the ability of the atrium to fibrillate. In other words, once we found out what was happening when the atrium was fibrillating, then we could develop a way to prevent that from happening, and that was the genesis of the Maze procedure.
Okay. There is a concept in your papers that you have published previously, and I read the critical mass concept. The critical mass in these cases I would like you to explain us the critical mass concept, please.
Yes, in the atrium, because it's usually thin or it's not real thick as opposed to the ventricle, it's not so much a critical mass as it is a critical area. So we know that there has to be a certain size area available to participate in the atrial fibrillation.
Yeah.
And during the atrial fibrillation, there are large reentrant circuits, reentrant spiral waves going around in the atrium, and they're moving around all the time. But they require a certain amount of area to develop. And if that area is not available, they can't develop. So the idea was to put the surgical lesions close enough together so that those big spiral or big rotor waves could not develop. And if those could not develop, then by definition, the atrium can't fibrillate. Now, the reason the term maze came along is that one way you could prevent those big circuits from developing is to simply breadloaf the heart, the atrium, into segments, individual segments. The problem with that, of course, is that even though it will certainly get rid of the atrial fib, the atrium won't function after that. So by putting the lesions in a maze pattern, it allowed us to, one, get rid of the big reentrant circuits, and two, it then allowed the heart to take over as a sinus rhythm, the normal rhythm, and activate all the atrium and have it function.
Okay, this concept is very important because you have an electrical impulse guided from the sinus node to the atrioventricular node while activating all the atrial tissue. But I have seen in almost all cases after Cox-Maze-3, for example, that there is a delay of the electrical impulse, so we can see an ampere interval larger than normal. Is it normal in this case?
Yes, it's normal because what we learned with the left atrial isolation procedure years ago is that the P wave on a standard EKG is generated almost entirely by activation of the left atrium, not the right atrium. And after the maze procedure, the left atrium tends to activate a little bit later, or in some cases maybe even earlier, but it changes the activation sequence such that it can affect what you see as the P wave on the standard EKG. So sometimes it looks like it's prolonged, sometimes it's even a little bit shortened, but there is an expectation. It doesn't mean you're creating first-degree heart block because you have no effect at all on the AV node.
Yeah.
It just is the interatrial conduction changes that cause the EKG to change a little
Okay,
bit.
this is very important.
Yes.
To understand.
Yeah, it's important to know that that heart block is not a complication of the maze procedure.
And another question, the rheumatic disease. The mitral valve disease, rheumatic cases, for example, as you know, all people know that almost 50% exhibits continuous atrial fibrillation in these cases around. So the fibrosis in these cases, what is the role of the fibrosis in these cases in the genesis of the atrial fibrillation? Is it different from the cases that there are not valvular atrial fibrillation?
Yes, it's a little different because the fibrosis does play a role in it. And what the fibrosis does is it slows the propagation of the electrical impulse so that you can have a smaller area. You know, if the atrial wall is thick and fibrotic, then you can have a smaller area that will sustain these reentrant circuits. And that means that the maze procedure, although it's still quite successful in those patients, it may be a little bit less successful in the rheumatic patients. The extreme of that is if the atrium is really thick,
Okay.
and it's it looks like it's not going to function even if you get rid of the atrial fibrillation. In some of those patients, you probably should not do it, because it's not going to do much good. But in general, just the fact that it is primarily a rheumatic disease process does not rule out the benefits of the Mays procedure in most patients. But if the atrium gets really thick, then that can be a problem.
Another question. I have found that the success rate in the papers about Mays procedure, talking about, in example, 55 persons, 75 persons of success, and they are present as good results. So I don't think so. What do you think about that? Is for the follow-up?
Now, I have two comments about that.
Okay.
First is I'm not sure who lowered the bar. Who decided that 70% is a good result? I think that when you went through medical school, I'm sure there weren't many tests where you made only 70% of it, or else you wouldn't have gotten through medical school. So we're not used to getting 70%. 70% is failure. So I don't like the idea that people consider 65%, 70% as being good, not for a surgical procedure. My second point is that the vast majority of those results, if not all of those results, come from the fact that they're not really doing a Mays procedure. I use the term Mays procedure, but as you know, there are at least 4 different Mays procedures. Someone once sent me a book that had 2,000 mazes in it. They were all mazes, but they were all different. But they all adhered to the Mays principle, the Mays pattern. And I think that's the critical point, that when you treat atrial fibrillation surgically, you should adhere to the principle of creating a maze. Now, how you create the maze or how I create the maze may be two different things. But in patients who have, for example, just left-sided lesions, the atrial muscle in the right and left atrium is all one electrical muscle mass. And if you just address 1/2 of that muscle mass, you have not created a maze. And so you must create a maze in the entire muscle mass. Each lesion must be perfect, and you have to be sure there are no gaps and things like that. And the vast majority of failures in patients undergoing so-called Mays procedures is because the procedures were not performed correctly. It's not because the energy source fails or anything else. It's because the operation was done incorrectly. My analogy is this. If someone gave you a really great aortic valve prosthesis and said, here's a new prosthesis for the aortic valve, it's wonderful, put it in. And you go and put it, you say, okay, I'll put that new valve in, but I'm only going to put 3 sutures in, because I don't want to do those other sutures. It takes too long, it's too hard to do. I'm just going to put 1 suture in at each commissure. And you put it in, and the valve sits in place, but it leaks, like crazy. And then you come back and say, well, that valve is no good. It's not that the valve is no good, it's that you did the operation incorrectly.
Okay.
And so that's my analogy. It's the same way with the Mays procedure. The Mays procedure, in the hands of people who really know how to do it, works almost every time. And we have long-term results of success rates of over 90% from several different authors. Not just me, but Hartzell Schaff and Neve Ad and Ralph Damiano and your own results. These are all people who really know how to do this procedure, and they get superb results. And in most cases, if you don't get good results with the Mays procedures, because you don't know how to do it.
Okay. And the main questions. What to do when Mays has failed? As you told, the success rate in all the vast majority of the cases of the Mays procedure is higher than 90%, 95%,
95%.
95%. Okay. But, however, there is a little number of patients that exhibits again atrial fibrillations. Overall, the patients with rheumatic cases in a large follow-up newly or again exhibits atrial fibrillations, and the Cox-Maze procedure has done or has performed in these cases. What to do, considering that you have removed the left atrial appendage, in cases, for example, in biological mitral prosthesis or mitral valve repair, what to do in these cases in relationship with the anticoagulation?
Mhm. Well, assuming you've done a mitral valve repair or a tissue valve that you don't need long-term anticoagulation, if the patient has had a Maze procedure or something called a Maze procedure and has had the left atrial appendage removed, then we know that that patient's not at a higher risk for stroke if the patient does not have a left atrial appendage. So how you treat that patient depends on the patient's symptoms. For example, if that patient is symptomatic, then you would have a couple of options. You can treat the patient with medicine and hope that that will now, with the help of whatever procedure was done, will now work. Or as a final action, you could ablate the His bundle and put a pacemaker in. If the patient is not symptomatic and doesn't have a left atrial appendage,
Yeah.
I don't think you need to do anything if the heart rate's not too fast.
And anticoagulation.
Anticoagulation, I don't think is ever necessary once you've removed the left atrial appendage.
Exactly.
So the anticoagulation has nothing to do with the symptoms. It has nothing to do with the atrial fibrillation. I think atrial fibrillation without a left atrial appendage is like having an aging spot on the back of your hand. If you don't have symptoms, you're not at risk of stroke. Why bother with it? Why bother with it?
Okay, very good. Finally, your concept about the alternative energy sources to perform the Maze procedure.
There are two energy sources that I believe have withstood the test of time.
That's right. This is the question.
One is bipolar radio frequency.
Only bipolar.
Only bipolar.
Monopolar is
Absolutely
not.
should not use unipolar. Unipolar energy sources are unipolar RF
Okay.
is just not an adequate energy source. This is the biggest problem, in my opinion. One of the big problems that the catheter ablaters have. They use unipolar RF.
Because the
It is-
transmurality
yeah,
is not
you just can't-
assured.
You cannot assure transmurality. And you cannot assure that, in their case, that each one of those dots overlaps the next dot and so on. You're trying to create a line with a bunch of dots. Professor Passaguer from Bordeaux, France,
Yeah.
who is the person who invented catheter ablation for atrial fibrillation.
Okay.
I had dinner with him many times, but I had dinner with him once in Bordeaux about 3 years ago. Might I borrow this? And he said, he said himself, he said, trying to create a line with the end of a catheter is like trying to cut off the
Point
edge
by,
of the stick.
point by point.
Yes. He
No,
said
this
it's
is
like,
very difficult.
he said it's
Is
like
it
trying,
possible?
he said it's like trying to cut off this corner of this paper by taking a straight pen and making lots of holes. He said eventually you can get it, but it's a lot easier just to do it this way. So the problem that the catheter ablaters have is they don't have the correct tools to allow them to do what we can do surgically. That's why their results aren't as good. But, you know, their results don't have to be as good because they're not opening the chest.
Very good. And the cryolation?
Oh, I'm sorry, I didn't get to the second one. Cryosurgery, I believe, is the most reliable energy source there is, if you know how to use it. And I've used cryosurgery since the mid-1970s, long before we started developing the Maze procedure. And if you know how to use it and you're patient with it, it is just as good as cutting it. And in matter of fact, one of the big mistakes that people make is they equate the term Maze 3 procedure with the cut and sew. But over half of the Maze 3 procedures that I personally performed myself were done strictly with cryoprobes. The Maze 3 lesion pattern, but using only cryoprobes. Only cryoprobes. And Neve Ad, one of my proteges who's in Washington, D.C., has done over 1,000 Maze procedures.
Only with cryoprobe?
Only with cryoprobe. That's all he ever uses. So the cryo, you can do them also with radiofrequency clamps, although not quite as well. But the cryoprobe, I believe, is the best energy source if you know how to use it. On the other hand, it is a unipolar source, like unipolar radiofrequency. So if you have a beating heart, let's say, with blood inside it going at 5 liters a minute, and you could put a cryoprobe on the outside of the heart, you can never get reproducible transmural lesions with a cryoprobe. I don't care how cold it gets, or what the circumstances are, because it will not work from outside the heart if the heart's full of blood and it is beating. The reason is not that the blood inside the heart's 37, so is the tissue. The reason is that the blood's going at 5 liters a minute. Yeah, and you know, there's no such thing as cold. There's no such thing as cold. There's only the absence of heat. And so the way cryoprobes work is they withdraw the heat out of the tissue. And once they withdraw the heat out of the tissue from the epicardium, it's going down towards the endocardium, it gets to the blood. The blood is going by so fast that it just simply can't extract heat fast enough. So it will not give you transmural lesions.
Okay, there is for the audience, when the surgeon use the bipolar clamp, for example, in a case of atrial fibrillation surgery, the bipolar clamp is applied in this way.
Yes.
But there is two important points to talk. The contralations in the mitral and the tricuspid annulus, and another point in the mitral valve, the isthmus of the mitral valve. So the bipolar clamp can't be joined together until the valve, until the annulus of the valve. So in this point, what would be your recommendation? Cryoprobe, radiofrequency,
Cryoprobe.
cryoprobe.
Yes.
Totally.
Yes. I think it's very difficult to get essentially perfect results without a cryoprobe. Now you could do maybe the whole operation with clamps, radiofrequency clamps, but you need to have a cryoprobe at the valve annulus where you're talking about, because you can't get the tip of the cryoprobe all the way. Even if you get it to the annulus, the distal tip of the the radiofrequency clamp, you can't get it all the way down to the annulus. The only way you can do that is to go across the annulus, and then you run the risk of applying radiofrequency to the valve leaflet, and that's damaging to the leaflet. So you can't get a perfect lesion there without a cryoprobe.
Okay. This is very important for the audience to do in the cases of Maze procedure. And finally, I'm very grateful with your Master Cox, because Master Cox has teaches to me to distance via email, like online, lessons, many of secrets of in atrial fibrillation surgery. I appreciate really your patience and your willingness, and I thank Master James Cox and appreciate you making this great effort to attend to this order.
Well, thank you so much. I'm really enjoying myself. Thank you so much.
Thank you very much. Okay.